Hello, and welcome to today's health webinar. This episode is brought to you by our friends at Microsoft. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Arnaud Villemay.
Good afternoon, everyone, and welcome to the Microsoft HLTH Europe webinar series. I'm delighted to welcome you to today's session, Shaping the Future of Healthcare, AI, Access, and Action. I'm Dr. Arnaud Villemay, Chief Medical Information Officer at EMEA at Microsoft. I'll be moderating today's discussion. Healthcare is currently experiencing a significant generational transition. AI is no longer a future promise or a lab experiment. It is beginning to reshape how care is delivered, how clinician works, how research translates into practice, and how patients engage with their own health. We, healthcare leader and healthcare provider, are experiencing a pivotal transformation that will shape future generations. What makes this moment different is speed and scale. We are seeing decades of progress compressed into a few years, and that creates both extraordinary opportunity and real responsibility. Today's conversation is about moving from experimentation to impact. We will explore how generative AI and agentic AI are already influencing hospital strategy, clinical workflow, research, and leadership decision-making, and what it really takes to turn innovation into action. I'm delighted to be joined today by three exceptional leaders, each bringing a unique system-level perspective. Dr. Penny Dash, Chair of the NHS England, welcome. Dr. Florentin Canis, Strategy Advisor at Charité, University Medicine Berlin in Germany. And finally, Magnus Kjellberg, Head of the AI Office at Region Västra Götaland in Sweden. Thank you all for being there with us today. Penny, may I ask you to start? You briefly introduce yourself and your current focus.
Hi, everybody. My name is Penny Dash. I am chair of NHS England. That means I chair the board that has overall responsibility for the health and healthcare for 55 million people. We are desperately trying to improve the service, to improve health outcomes, to ensure that we look after people in the most appropriate way. That means in a primary care setting, a community care setting where appropriate, and that we have high quality and efficient healthcare services. And those last two potentially could see a real step change and improvement from the adoption of technology, including AI. So I'm looking forward to talking about that more today.
Thank you, Penny. Florentin, your turn to introduce yourself.
Yes, thank you so much. Thank you, Arnaud, and hello, everyone. My name is Florentin Canis. I'm the Chief of Staff to the CEO of Charité in Berlin, one of the biggest European university hospitals. And I have both a medical background, so I used to work as a neurologist, but in a former life, I was also working in venture capital investing. So I'm really excited about today's topic from basically both our two different angles. From the investor perspective, being excited about all the new innovation opportunities that arise with this, but on the other hand, also as a medical doctor, being really, blown away by all the opportunities that might arise from for clinical care, from all the different technologies that we can imagine and that we are going to talk about today.
Of course. Magnus, it's your turn to introduce yourself.
Yeah, so thank you very much for having me. Good afternoon, everyone. So I'm Magnus Kjellberg. I'm heading the AI office at Region Västra Götaland. It's on the western part of Sweden. Actually, I worked in the AI in the healthcare sector for quite a while, and I used to head, or I'm still heading 50% the Center of Excellence on the University Hospital of Sahlgrenska University Hospital. But since a year ago, I'm also heading the regional AI office, and the region comprises of 21 hospitals in 5 different clusters and also primary healthcare, etc. So, and there I'm focusing more on the adoption strategy and these kind of things. So I'm looking forward to these discussions today.
Thank you. So to guide the discussion, we structured today's conversation. It's around 3 themes. So AI, innovation and strategy, access, democratization, practice and equity, and action, interoperability, governance, and measurable impact. So Let's start with AI and strategy. Strategy looks very different depending on whether you're operating at a regional, national, or academic medical center level, and that diversity of perspective is exactly what makes this panel so powerful. So Magnus, I'd like to start with you, and I will have the same question for each of you. From your perspective, at the region GoTalent, what is the primary goal of your current AI initiative today?
Yeah, so I will try to have the regional perspective, but you need to stop me if I get blown away, because I think the AI sector is so interesting, and I might get carried away. And so you need to stop me if I get carried away with
I will.
technology questions.
But we want to hear about it.
No, yeah, of course. But I think sort of our primary goal is, of course, to improve the health outcomes and quality of life for our 2 million of residents in the region. And I think we have sort of identified 3 areas where we see mature AI technologies and where we can sort of deliver measurable impact within 3 years in the short term. So administrative automation and planning, aid in repetitive tasks, etc. We have clinical documentation workflows, of course. There's like a lot of potential there. And we also have an area, the third area is the medical imaging decision support, where we both for screening and clinical diagnostics and high volume workflows, basically. So I think these 3 areas are important, and we're sort of moving away from only experimenting and to some extent scattered implementation, moving into the sort of more kind of systematic implementation within these 3 areas. But we still need to, of course, continue with experimentation in different areas across the healthcare sector.
And follow up with Penny, from a national leadership perspective, especially you're serving 55 million people. So what is your AI, the primary AI initiative? I know it's a broad question, but I think it's important to hear also at a national level.
So there's a few. I think first off to say, we're excited by the potential as others have described. What we're thinking through is how do we encourage and support the adoption of AI in a sensible way across the country. So what we're certainly not going to do at the national level is tell an individual doctor, nurse, paramedic, physio how to use AI locally. But what we would like to do is, first of all, make sure that we are sharing examples of where AI could be used and the sort of benefit that it's having. We're seeing some really fantastic results from things like ambient voice technology, from AI supported diagnostics. We can see those examples. Some of them are known about, some of them are shared, but nothing like as much as they could and should be. So that's sort of one bit. Say almost, we can play a sort of knowledge center role of sharing those real use case examples. The second is that we think there is some benefit in doing some national procurement. So, for example, on ambient voice technology, we are looking to have a national procurement for that. That's what we think would make sense. That's what we hear from industry. Many of the suppliers say that, why can't you just procure this once rather than having to go round every single different hospital and every single primary care practice. So we think we could do that. That would then give us a sort of essentially a drop-down menu that people could then choose from. And we are hopeful that that will accelerate spread. The third is that we absolutely need to make sure that we are evaluating, that we're looking at what is having what impact on quality and on cost. The fourth bit is that we are factoring this into our future workforce planning. So as we're thinking through as a country, what could the future workforce look like? How many doctors do we need to train? How many nurses do we need to train? That we are thinking through what will the impact of AI be on those jobs in the future. So we've got an active piece of work on that. And then the fifth area is that the main regulator of medical devices, it's called the MHRA, has launched a 6-month piece of work, which is called the AI Commission. Sounds quite grand, but they are looking to explore many of these questions and say, where do we think AI will really have impact in healthcare services? How do we adopt that at pace? But also, what are some of the cautions that we might need to have in how we do that?
So it's kind of guiding the people, evaluation, quality, and also the topic about medical device. What about you, Florentine? At Charité, well-known academic hospital in Germany and globally. So what is your primary goal of your AI strategy at the academic level?
So I think it will be difficult to just point out one strategy. And as both Magnus and Penny were saying, you know, there are all these different areas where AI can be useful. So obviously we are exploring all these areas just as well. But let me say that I think there is already a strong pull from our medical staff or even our scientists. So that way we have a few pilot projects in different areas that are both helping either our staff and workforce or the patients themselves. But that's really on a pilot level. And at the same time, we're also working on this, grand AI strategy that really will gather all these different aspects together. And we've just named a professor for artificial intelligence in medicine. He's a very impressive person. Alexander Meyer, he is a heart surgeon and a data scientist. So, and he is leading a new institute for AI in medicine as well. So we are kind of approaching it from both angles, more the academic perspective, and then also really the hands-on pragmatic approach, because as we all know, things are moving forward so fast. No one of us can predict where we're going to stand in just 1 year from now. So it's really also a new way of approaching, this paradigm shift, let's really say it this way, that we cannot, as a big institution, just say, well, let's have a strategy and then look at things and then, slowly evolve. But we really need to have both implementation and the academic perspective.
Thank you. I'd like to come back to you, Magnus, and deep dive a little bit on your strategy over there, and especially regarding data and interoperability. So I know it's been one of your key topics. So can you tell us a bit more about it?
Yeah, sure. So I mean, no AI without data. I mean, that is true. So data is really important. We have invested quite a bit in the past, and we are continuously doing that. I think we would like to see our data platform, our data as the heart of our future systems, and we're actually building our next generation health information management system, and that will be a module-based system, but the data platform will be the heart of this, and we believe that this is like a kind of a future-proof architecture. So data is of course really important. I think the other one is organizational alignment. I think it's important to acknowledge that AI is not an IT question. You shouldn't place the AI question within the IT department. You need to make sure that sort of the AI innovation comes from the clinical needs, and the clinicians are on board, and the CEOs of the hospital are actually driving this endeavor, and make sure that we fulfill the clinical needs. And I also think that it's important we need to adapt our current governance models and structures, etc., to AI. And we are not creating any specific AI paths. I think we are just changing the way we're handling innovation and make sure that we can handle AI as good as possible within the current governance models. And then finally, I think what is quite interesting nowadays now with this AI revolution is that it's so available to staff and to patients privately. I mean, we need to make sure that we can actually use this sort of curiosity and the knowledge that comes from their private use of AI technology. And so I think having staff and to some extent patients as co-innovators in the AI field is also an important one.
So you have patients engaged in your strategy for AI?
Yes, to some extent. I mean, this is something we are experimenting with staff, of course. That is not simple. It's difficult as well, but I mean, that's more clear. And the patient involvement is another one that I think. But I think there is a big opportunity for us to also look at how are patients using AI, and can we learn, can we adapt and use some of their approaches.
And Florentine and Penny, same approach with patient. Yeah, it's something I think it's very important. We know we try to engage clinician in an early stage, but patient is very important too. So just very quickly, any thought or any things to share about that? Penny?
Well, one bit I might just add is actually it's also about making sure that you've got good alignment of operational management with AI. Because one of the things that we've seen is, interestingly, clinicians actually seem very keen, which is good. Thinking through some of the rejection and bad press of previous technology, whereas things like ambient voice technology, is certainly being quite rapidly adopted by clinicians here. But what isn't happening is necessarily linking that into the wider management, the operational management of services. So, for example, we've got outpatient clinics using ABT, finding that that's generating a 15%, even 20% productivity improvement, but then we're not then changing the outpatient schedule. So we're not capturing the benefit of that. So that's one simple example, but there are many examples like that. So it's really about how do we fully integrate these products into our operational practices.
Yeah, I think that's a key challenge. Florentine?
I really want to agree with what Magnus and Penny said. I think it's dramatically underestimated what patients or how patients are already today using AI, and how they just learn that way to really have more equity in their own health, and a kind of a informed base for the decision making. And I think that will become more and more challenging for medical staff, and I think we might also touch later on that, but
yes.
So I think right now we could still, it's challenging, and we could still do better in really involving patients in these processes in a more structured way. But that's challenging. Also, what Penny said, across the sectors that we have. So in Germany, we have a very strict separation between the inpatient and the outpatient sector, which of course for us as a hospital makes it even more difficult to use the capacities that those patients might have, before and after, like before they come to Charité and after they leave the hospital. But that's certainly the future for sure.
And with your experience with startup, if we look like 3 to 5 years from now, how generative AI and agentic AI will reshape clinical workflow? And do you see any specific area will be live first?
That's an interesting question, and I think 3 to 5 years is ambitious for
I know.
For a big organization. So, but as I said earlier, again, the technologies and the world around us and reality is not waiting for us. So the patients are just going to use it anyway, and even our staff, they just are going to use it anyway, if we're ready or not. So I think we really have to focus on that. One challenge that we have is that we have just chosen, as many of you have seen, we had a big tender to procure a new clinical information system, and it had been a big news, at least in the German ecosystem, that Charité decided to go with Epic. This was in news in December. And so, of course, now most of our capacities are steered toward, having this huge change process that comes along with implementing a whole new system. And of course, we're also very interested to see and to shape and to design how we are going to implement AI kind of going along with it. And then I think it will be interesting, if you ask me 3 to 5 years from today, if the patient engagement and all the patient solutions will kind of overtake, the solutions for process management and for decision support and diagnostics support, or if those areas can also catch up. So I think that will be a very interesting bet and an interesting race, so to say.
Yes, and moving to a new EMR system, it will be a good way for you at Charité to re-engineering the clinical workflow as well, and change management. So yes, and yes, agentic AI it's a game changer. We hear a lot about agentic AI right now. I'd like to hear from Penny and Magnus. What is your thought and your vision that this autonomous agent, and I like the autonomous agent title, support clinical decision-making with still human oversight in the future? Because I think we are right now in the race of having this agentic AI working for us as assistant, but also autonomously. So what is your vision about that? And I think it's all physicians are waiting for this.
Yeah, I mean, I think it's hard. It is hard to know. I quite like the line that, will AI replace doctors? And I'm assuming not fully, but will you be a better doctor if you're using AI? Absolutely. So I think we need to, almost approach this through that mindset. And so if one thinks of the sort of, there's no way you can capture the wealth of medical knowledge. I mean, it was hard, when I trained 40 years ago. There's even more knowledge now, and it's even harder to learn all of that. And so the reality is people aren't learning it all. And therefore, this is where different tools will come in and hopefully AI will support them. So that's one bit. But the second bit is that the ability to interpret, particularly diagnostic scans, in a way that the human being will never quite be able to have that even better level of sophistication. That for me is the really powerful bit. So then the role of the doctor changes from the person who has to do everything, listen to a chest, think through what's the heartbeats that I'm hearing, understand what that means. We're going to take all of that away. You won't do that. Everyone will be connected to an automated ECG heart monitor that will automatically tell you what's happening. But what your job will then be is in some ways to become more caring and to provide the interpretation and help the patient understand what this means for them. So it is quite a fundamental shift. It's a shift from being a sort of who's got the biggest brain that can hold the most information, through to being, who's the person who can interpret this information, work with technology in the most impactful way to support their populations and their patients.
Magnus, your experience in Sweden with
Yeah.
your clinical community about that?
Yeah, sure. I think it's very interesting because, I mean, we talk about, if you clarify a little bit what agentic AI for me is, I mean, that is a system that actually takes actions, and we are very used to having chatbots or decision support tools where provide information back to the user. What for agentic AI, actually something happens as well. I'm not sure if we talk about clinical agents, we are definitely not there yet. I mean, they are starting to emerge. I mean, you hear it from across the world, so they are coming. I think, but it will take time. I think we're not ready. I mean, there are regulatory issues, there are ethical reasons, of course, accountability, responsibility, all these kind of things. We need to sort that out. So we are not ready. The technology might be to some extent ready, depending on the use case, but we are not ready as a society, I would say. So we need to discuss this first. But I mean, if you talk about administrative tasks, I think definitely we would quite soon have AI agents that would perform those kind of tasks within the healthcare system. So there I don't see, but from a clinical point of view, the clinical workflows, that will take a while. I think we need to discuss that quite a bit, because there are like, where do we see the human fit in the world of automation? I mean, that's something, and there are higher values than just being more effective. There are other things that we need to think about as well. Yeah.
Yes.
And if I may briefly comment to that, I would just like to add that I think it's just inevitable to have these solutions, because what we can have also to keep in mind is that our healthcare systems, you really look across all the Europe, but also the US and Asia. We have challenges that are demographics, for example, and we will have to lean more into approaches that are more personalized and also more preventative. And I think also here AI can have a huge impact on, understanding this kind of medicine even better and executing on it, so you can provide a more tailored approach, because we can basically not afford to practice the medicine the way that we're doing today in, let's say 30 years from now.
Yeah, and hearing you, and I think it's related to the strategy of the NHS England with evaluation. I think it's a key topic here, especially for this high risk environment, which is a clinical and with high impact. So no, today we can see autonomous agents more in high impact but low risk environment, and I think evaluation in a clinical workflow for us physician will be key. So we're going to move to our second topic, which is access. Just for everyone, you are able to actually put some question in the chat, and we will respond to them at the end if needed. So please feel free to write your question in the Q&A tool. So let's move now to access, democratization, practice, and equity. I'd like to start again with you, Penny. What does it really mean to democratize AI across the health system? It's not only giving the technology the solution, it's much more than that. So how do you see for NHS England, for 55 million patients again?
Yeah, so I was going to say, you just said, I was reading this, I could interpret the question in many ways. So let me sort of share a few thoughts. So one is, we need to make sure that these tools are available for all bits of the healthcare system, not just a hospital-based or a doctor-based. Actually, we see many tools being highly impactful for nursing staff and absolutely out in the community. So that's one bit. It needs to, we need to use these everywhere. I mean, mental health is a really interesting area where you can, I think AI has enormous potential. So that's one bit. The second bit there is the bit that Florentine was just saying. I mean, this really does have the potential to significantly reduce the costs of healthcare and therefore make healthcare far more accessible to the whole population. And I think that's a really big thing. So we do have in England a model which provides healthcare to the whole population, free at the point of use, paid for through general taxation. But there are many, many healthcare systems globally that do not have that, and where there are significant differences in who can access healthcare depending on income level. And so first, I see it as making it much easier in countries like England to actually provide a broader range of services, because the overall unit cost we are expecting to go down. But also, I think the potential to provide care to countries that don't have universal access is significant. So that in and of itself is really interesting. There's a gentleman who should get on called Devi Shetty, who founded the Narayana group of cardiac hospitals in India. And he gives a fantastic talk about how he sees the costs of healthcare absolutely dropping very, very quickly, and therefore really enabling access to improve. And his belief is that in the next 10 years, we will see all 8 billion people on planet Earth all have access to high quality healthcare by using AI-based technology. So that's a really interesting one. And then the third aspect of this is almost a bit about putting the control in the hands of the user. Because to date, the control has sat very much with the doctors in particular and the other healthcare staff. Whereas now it really is, we talk about, doctor in your pocket, and we put that in our strategy for the future of healthcare. But it really is that, it really is that you can, with your iPhone, of course, access so much information, monitor your own health status, understand as genomics comes along what you are personally at risk of, develop your own tailored healthcare packages. And I think, we are not far from actually then being able to almost administer your own healthcare, organize your own ultrasound potentially through an iPhone, listen to your baby's heartbeat through an iPhone, listen to your own heart through an iPhone. That is a real democratization of healthcare, actually, in a very significant way that 50 years ago, no one would have ever thought possible.
Yeah, so it's actually giving the innovation to everyone for a lower care. That's a good point. I think, Florentine, you start to approach this topic before, but January has been we hear a lot about recent news with ChatGPT Health, with cloud for healthcare. AI in healthcare is now in the hand of the patient. So how should an healthcare organization or academic hospital or physician respond to that?
Yeah, I think they have to respond to that quite different from what they used to do before. When you would just tell your patients, please don't Google.
Yes, but they do.
Right? I tell you something now, but please don't Google it. That's not how it's going to work. So I think they really need to seriously embrace it, and even make use of it. Make use of the new abilities for patients to access their own information, and of course also to contribute the information. As Penny was saying, all these monitoring devices that will make it so much more so much easier to get long-term information, and not just one point in time where you get data from your patients. So I think it really needs to be embraced. And for that, of course, probably both patients and doctors should have trainings. And since we cannot as easily access the patient community, I guess the first step is really to train medical staff to just work with it in their clinical routine.
And for you, Magnus, we also say that AI is described as a tool to advance health equity, and especially in a region where you are in Sweden. Do you have any example of how we can truly help, underserved population or communities? Do you have some example in your region?
Yes, sure. I mean, I think you already, both Penny and Florentine touched upon it, but I mean, like democratizing AI and the user and making decisions, I think there we see a big potential. So, I mean, one is we have had this kind of tool for like clinical decision support tool for our stroke care pathway, and we have it has been run for a number of years across the regional hospitals, and we see a lot of benefit, but perhaps not so much at the university hospital, but more on the regional hospitals, because they can make more advanced decisions, which were solely made on the university hospital before. But now they can make these kind of decisions on patient treatment, etc., and on the regional scale. So I think there you see one example, and the other one is something we already touched upon, where patient-facing AI and how we can develop these kind of advanced digital tools where patient can manage their disease on their own, like remote monitoring, but adding also AI-enhanced functionality for more advanced decision making at the patient level. I think there I see a big opportunity for both patient autonomy, but also for us as an organization to become more effective in that sense.
Thank you. I'm just going to take one question from the chat. I think it can be for all of you. In your opinion, how can we preserve the human connection between patient and healthcare professional while using AI? So who want to take this question? I think it's a key quick question. So how do you make sure we preserve the human connection when we are using AI with our patient?
Shall I come in? I'll go first. I think actually it's a bit about taking the opportunity to do something that we need to do anyway, even without AI, which is to provide this sense of a sort of care navigator. If I look at our level of healthcare resource use, as colleagues will have as well, we have a small number of people. Here it's 6% of people consume 60% of resources. You see that in many countries. And typically that 6%, it's around how they access the healthcare services. We don't make it easy for them. They don't know where to come to. They end up going, to an emergency department. I had an email from someone, they've been to the emergency department 5 times in the last 5 days. Well, someone should have picked that up and managed that. And one of the things I think that we could really benefit from here is that the care navigator becomes part of the AI product. So it's a combination of a human being and tools that are particularly focused on some of those different patient and population groups. And the risk is that we actually take our AI products much more to the sort of worried well, people who are otherwise healthy, whereas actually the place that this could be very powerful, but will need a human being attached to it, would be in some of those higher need individuals.
Any other thoughts?
Yeah, I think I was perhaps touching on that before, but I think we need to sort of have a overview view and see where do humans decision making, where do humans fit in. I mean, we can probably automate quite a bit of things, but what we're doing in the hospital or the healthcare, but we need to think about where actually humans should be, and perhaps that is where we should have human interaction. So I think that's, yeah, we definitely need to be vigilant about where humans fit in an automatic future.
Yeah. Florentine, you want to add something?
Yeah, I think it's a very important question, and I'm tempted to also just give this answer that is, everywhere already, that of course AI should be used for freeing up time so that the medical staff can actually spend more time with their patients and the hospital bed, right? I mean, I used to work in an intensive care ward, and there they also sit outside the patient rooms, and just, you had to document all the time, and all this work, of course, can easily be replaced and taken up by AI agents in some future, hopefully, and then you will have more time in interacting with your patient, and especially in these kind of settings, it's so important to have this human interaction. We know that how important it is for prevention of delirium and better outcomes and so forth.
Yes, and I think that's what we really witness with this new ambient technology, and we at Microsoft, we have a Dragon Copilot to just really give back time between physician and patient, and what we can see, it's put back the human between the physician and the patient. So it's a key topic. It's really humanizing again, what we do. And I'd like to have from each of you, if you have one AI practical use case, have you heard that really improve clinician and patient trust? Patient trust is like the main prerequisite for patient acceptance and therapy alliance. It's the foundation of physician-patient relationships. So did you see anything right now in technology that'll bring more trust between patient and physician? Magnus, maybe?
Yeah, I can go first. Yeah, I think one example where we're using AI for fall prevention, movement monitoring, basically, and then like an AI analysis of radar signals. And I think we are rolling this out across all hospitals within the region, and it's sort of, I think the staff have felt much more comfortable. It's a validated solution. It's a transparent system, and also from patients and families, they're also very happy, and they can see what's going on. So in that sense, I think we are sort of increasing the trust in how we're working with how we're applying AI in healthcare.
Yeah, I'll go. I think we're a bit early, to be honest, to fully see this, and but the one very positive use case from here is around the use of ambient voice technology. And what we're hearing is that patients really appreciate that now the doctor is looking at them, is not looking at the keyboard or looking at the computer. And so that, number one. And then secondly, they really appreciate, particularly in a hospital specialist outpatient setting, they get the notes of the consultation within 5 minutes. It goes to them as well as into other bits of the system. And so those two bits, sort of fairly quick and easy and immediate bits, are certainly getting very positive feedback.
Thank you. So we're going to move to our last theme, so action, interoperability, governance, and impact. I'd like to come back to you, Magnus, especially with your data foundation. What has been the biggest challenge you face in achieving data interoperability across system, and what did you do in your job to address that?
Yes, so I mean, yeah, no AI without data, of course. So as I mentioned before, so I mean, of course, we're working with we want to standardize our data using these kind of standards, Open EHR, FHIR, OMOP, etc. But I think and we have big efforts in standardizing the data, but I think what's also important is to actually standardizing how we work. So that is sort of the foundation of getting standardized data is actually, we work in this similar way across the hospital within the region. So that is one important thing. I think another one is around secondary use of AI, and for research purposes, we have focused quite a bit on using privacy enhancing techniques and how we actually can do analysis across hospitals, cross organizations, and using federated analysis, etc. And there, it's very important to have standardized data. Otherwise, it's impossible to do cross analytics, basically. And I think also, I will, if I can move into the technical sector a little bit, one reflection, I think it's very interesting tension where it's sort of emerging. We push very hard for standardization, but at the same time, we see that this kind of new AI technology is very capable of handling unstructured data, clinical notes, free text. So I think we need to rethink a little bit how we actually approach standardization, when we should do it in the life cycle, how we should do it, etc. I don't have an answer there, but I think we need to grasp the AI, sort of the AI development, and understand, use that in the standardization process as well.
Yeah, because I think standardization has been our 15 last year strategy, and now with all generative AI, as you say, you don't really need standardized or consolidated data to make things happen. So yes, it's I think it's also a change of mindset that we all need to have. For Penny and Florentine, and also maybe Magnus again, how important is cross-border data collaboration or cross-system to accelerate AI-driven healthcare innovation in Europe? Maybe we start with you, Florentine. You moved to a new system at Charité, so it might be one of your thoughts, but I'd be happy to hear more about that.
Yeah, thank you. It's true, and thanks for mentioning it, because I saw one question in the chat was about our decision making for Epic, and I guess most of it is undisclosed about all these different things that factored into this decision. But one might have been that there is this community around the Epic users. And I think what we can all relate to is the data quality, and especially also in rare cases, you really need a lot of data in order to really come to a good case. And so I think that's one thing. Federated data is super important, as Magnus already said, and to have really good management around that. And I mean, the infrastructure, I mean, for federated for projects that are based on federated data, you really need the infrastructure for that, right? We need the people who do the work, and the governance for that as well. And on the other hand, it's also a great opportunity because the regulation makes it much easier. If you, for example, if you imagined we have a European University Hospital Alliance, and if you would imagine that you would have a use case across all the different hospitals, then it would be much easier regulatory-wise, because we're all using our own data then in this platform. And then it would be quite easy to really make this then accessible to our patients, at least in our institutions then going forward.
And you, Penny, with a NHS lens,
Yeah. So I think this is a two-way bit. One is we need data for AI to work, obviously, and the more that we can have shared data systems, the better. Equally, I'm really optimistic that AI will generate a significantly improved caliber of data for us to then use for forward work. So I think that's a key bit, and how we then capture that into research, into evaluation, into sharing. And so we should now absolutely have the potential to have much more sophisticated case mix analysis, for example, to understand outcomes based on patient phenotype or patient condition in a way that would then give a lot more confidence to looking at that outcome data. So I think it's sort of a two-way process. We need really good data sharing to get the data in. We need really good data sharing to get the data out, and then in order to be able to analyze it.
So what do you think should be, is there a specific governance model to put in place before healthcare organization confidently deploy agent in high risk environment, like, a clinical workflow, I think that's what you explained about data foundation, but what governance do we need to put in place and probably for evaluation?
Well, I mentioned one thing that's happening here in England, which is this AI commission, where we're basically trying to do that on quite a significant level, which to really sort of set out how do we adopt this in a sensible way that we are continually learning from the rollout. I think that's a really good area also for cross-country collaboration. Everybody is rapidly running into this. How do we make sure that we all rapidly learn from each other?
I can also add that obviously here the digitalization, which I have to confess, still the level of digitalization in the German hospitals or in the outpatient setting is not as you would like it to be. And just the other day, I have this little vaccination passport, and someone tried to squeeze in something there in some extra line. So I was like, well, if we would have it all digitized, we wouldn't have this problem now. So for sure, the data quality should also increase if it's not the human factor anymore that messes with the data quality in some way, right? That if you have it all digitized and coming from the machine, it should be much easier as well and much more standardized, just automatically.
And do you have any evaluation program at Charité already?
What do you mean by evaluation program?
To make sure that the AI has been evaluated before it's been deployed.
Yeah, I mean, for sure, we cannot just, adopt any, as I said, most of the projects so far are pilots anyway. So they have a thorough process that accompanies the whole project. And in order also then in the end to evaluate if you want to scale and if you want to roll out across our 4 campuses.
And based on your experience, you're in an academic hospital. What do you see the key success factor for translating AI clinical research into scalable clinical solutions that are safe, regulated, and impactful for the patient? Any topic about that? So you do at the academic hospital, you probably do a lot of research on AI. So how do you move from research to actually execution?
Sorry,
in the real workflow?
I missed that. That was the part. So can you just the beginning of your question again, because there was a little break in my connection here.
Sorry. Meaning that you're an academic center, so you probably do a lot of research regarding AI right now. So how do you move from this research experiment to solutions that will be live in your organization? So I think it's a critical topic for everyone.
Yeah, it's for sure it's a critical topic, and let me be honest, of course, right now it's still a challenge because we also now in this transition phase of deploying this new clinical information system and the new EHR. So it's right now we're actually in this transition phase where sometimes it's difficult to really say, okay, we have a full rollout now because we don't know yet, just until end of last year, so about a month ago, we didn't know yet what kind of system we were going to have. So from now, this really starts kind of exploding probably to work on this change process to implement the new clinical information system. But then on the other hand, of course, also trying to complement it with all these different AI use cases. I think one kind of a nice approach that we see, I think, a lot in radiology imaging, just to give an example, is that there are these the companies that offer, kind of a marketplace or a platform for all these different AI use cases that are already tested, that are already, where you really know it's all compliant and interoperable. And I think that could be one strategy to also in other settings to make it feasible to really adopt and roll out.
Okay. Penny, how should leaders define success for AI in healthcare? And what are the risks of choosing the wrong metrics?
Yeah, well, I mean, of course, the wrong metrics have been used and chosen in the past. So, again, what I hope, I don't know whether this is too optimistic, but I hope that by using AI, we're going to get much, much, much smarter on what are good outcomes of healthcare. And as a result, allow us to be much, much smarter about perhaps what we shouldn't be doing. Where are there low value interventions and things that don't have big impact? So I think the first bit is to say, can we see a difference in terms of the health outcomes? And that's where, in many ways, I'm most optimistic. I think if we look at, certainly we've got good data, good analysis here in terms of, for example, the numbers of medication errors. Well, if we're using AI, if we're using scanning techniques and so on, we should largely be able to get rid of medication errors. We won't necessarily be able to get rid of the patient side, but we may be able to do that if we get much smarter monitoring. But we can certainly get rid of the errors in the administrative side and the dispensing side and so on. So that would be a real, tangible metric. We know how many errors there are now, more or less. We've got good estimates of that. That would be one that we could look at in the future. My other one would be diagnostic errors, which, problem in many countries. Human beings aren't infallible. They make mistakes, they miss things, not always easy to see. If we could start to see those diagnostic errors reducing, that would be another very powerful one. So those are sort of two immediate ones I'd like to see. I think that if we could manage those, we ought to then start to see much better health outcomes overall. People are taking more care of their own health, they're getting the right care at the right time. And finally, we should start to see a productivity gain from this.
So I think we are 5 minutes from the end of this webinar. So before we take some questions, I'd like for each of you in one sentence, what will be the single most meaningful use indicator that AI is improving access and outcome? I want one. It's not simple. So for you, what will be? You understand?
I think I already gave one, so I'll hand over to the others.
Yeah, I know you.
Yeah, okay. I'm not sure if this is an indicator really, but I think when AI becomes sort of invisible infrastructure and clinicians, patients don't think about using that they are using AI, and we just get better health outcomes and increased quality of life. I think that would be sort of perhaps not an indicator. It's more like definition of done or something. Yeah.
You, Florentine?
Yeah, to be honest, my answer would also be between the quality of life indicator, which should always be the most important indicator in medicine. And then the second, from an economic standpoint, would be the productivity gain that Penny already explained.
Yeah, I think productivity, quality of life is very consistent to everyone. So we're going to move for the questions. So I'm just going to look, maybe Dr. Dash, you mentioned the critical need for system-wide efficiency. We are seeing a massive shift where AI can now deliver clinical grade diagnostic in a patient pocket. From an NHS governance perspective, what is the biggest barrier to integrating this patient-generated data directly into clinical workflow? And how can innovator help you to bridge that trust gap?
So one of our biggest issues is legal frameworks which prevent data sharing, and actually quite a lot of clinical resistance to data sharing. So much as it's frustrating for patients, members of the public, that one member of staff can't see their other, that's because it's been blocked by clinical groups historically.
And I think that another question, how much medical device regulations, kind of the same topic, how much medical device regulation currently limits the adoption of AI in your organization?
Yes, I would say quite a bit, but I think that's perhaps not due to the medical device regulation itself. It's how we actually handle the regulation. So we are not really mature as an organization to handle it in a good way.
Same here.
So let's see. Let's see another one. There's long. So thank you for the good discussion. I wonder what you think the equity impact of having doctor in your pocket and patient net monitoring could be, and how we could reduce the potential negative equity impact.
I'll give a quick go. I think the positive impact, first of all, geography, within countries, but also globally, there are, places where it's easier to get to see a doctor by virtue of geography than in others. So rural areas, this potentially is really potentially very important. I think people who have mobility issues find it harder to get out, has real benefits. But also there are areas where people are reluctant to come forward. And that's, mental health, really interesting one there, that we're seeing a lot more people more comfortable using AI tools sometimes to discuss some of their mental health problems. So I think there's quite a few areas, but we've also obviously got to be careful that we don't have a negative impact on people who are less comfortable using technology. Hence my talk about the care navigators earlier.
I think there's a quick question for you, Magnus. The name of the stroke tool that you use in your region. You can share that.
Yeah, it's Brainomics, I think.
Brainomics. Okay, thank you. So I think we know at the end of this webinar, so all the questions that are in the chat, we couldn't respond. We will do it in a second time. I just going to do the closing. So we've heard today how this play out at very different level. And I like something that it's hard to know where we are going. I think also the key message about AI is there's so much change coming. So it's really hard for everyone to know exactly where we are going at whatever it's regional, national, or academic medicine. But one theme is very consistent. It's progress happens when strategy, responsibility, and action move together. The opportunity in front of us is significant, but so the responsibility. So if we get it right, AI can become a powerful force for better health and not just a new technology. Thank you, everyone. Thank you, Penny, Florentine, and Magnus for joining this webinar today. Really appreciate the conversation.
Thank you to Microsoft and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and watch the recording of today's session. Join us in Los Angeles, February 22nd to 25th for VIVE.